My name is Nicholas Short from MD Anderson Cancer Center in Houston, Texas. So we know that MRD is very prognostic in AML. So there have been two large meta-analyses evaluating this, showing that MRD is very prognostic for both disease-free survival and overall survival in AML. MRD is prognostic at all time points, including pre-transplant and post-transplant. Most studies have really looked at the role of MRD clearance initially with patients receiving frontline therapy. So for example, patient receives frontline intensive chemotherapy. We know that patients who clear their MRD have better outcomes than those patients who have persistent MRD positivity. That's been shown in many different studies. What has been less clear historically is what is the impact of patients who have MRD recurrence. So in other words, those patients who achieve MRD negativity and then don't go to transplant and then eventually are found to have a recurrence of the MRD after initial MRD negativity. So at this year's ASH meeting, we're going to be presenting our data on the impact of MRD recurrence in patients with AML. And what we found is that this is a relatively rare entity, at least in terms of to pick up clinically. So from a large population of nearly 2,000 patients, we identified only 55 patients who had MRD recurrence identified. And this was among all patients who had achieved MRD negative remission. This accounted for about 7% of patients overall. Now, the reason this was likely found only very rarely is because MRD relapses can happen very quickly in AML, and often, unless you're doing very frequent serial MRD monitoring, you may not be able to pick up on these MRD recurrence. I think an interesting thing that we found in the study was also that patients who have MRD recurrence appear to do worse than those patients who have MRD persistence. In fact, the outcomes of patients with MRD recurrence are more similar to those who have actual overt relapse disease. So among these 55 patients with MRD recurrence, about 2/3 of them just continued on their current therapy, and all these patients almost universally relapsed. So this is a very high risk feature that essentially identifies patients at a very high risk of relapse, certainly if no further interventions are performed. But we also look to see, well, what if the physician had intervened upon this new MRD recurrence, either by changing chemotherapy or sending these patients to transplant? And we found is actually a significant improvement in survival outcomes and a decrease in relapse in those patients who had undergone either a change in chemotherapy or who had undergone a stem cell transplant in the setting of MRD recurrence, suggesting that if we serially monitor these patients and identify MRD recurrence, it actually has therapeutic implications because we can intervene upon this and actually improve outcomes for patients. So I think the overall implications of this finding is, first of all, that MRD recurrence is a very, very high risk clinical scenario. That most of these episodes of MRD recurrence occur in the first year after achieving MRD negativity. And so it highlights that we really need to do very frequent MRD monitoring for patients, at least in the first year, particularly those who are not planned to go to stem cell transplant, because we can identify these and actually improve outcomes by intervening, either with a change in chemotherapy or sending patients to transplant. So I think this has important implications in terms of the need for frequent MRD monitoring for patients with AML, even after achieving MRD negative remission.